I'm very pleased that all of you could attend our Thrive, Not Just Survive seminar. This is about the 13th year that we have offered this seminar. I am coming to you today from the balmy Western New York, Buffalo area, and we just suffered another lake effect snow. And so all of this snow has kind of left me feeling somewhat flat, as you can tell from the projection of my image on the flat screen in front of you. Makes me feel a little bit like the Wizard of Oz. So what I'd like to do today is provide you with some useful as well as practical information on opting out of Medicare. The reasons for opting out of Medicare, most of you are pretty well aware of, and there are many. But one that has come to light recently is that of physician burnout. And I'm sure a lot of you realize, either your own personal experience or that of colleagues around you, that there's a lot of physician burnout going on. This is an article that was just recently published in Neurology. I'm a neurologist. And it was an article entitled, Physician Burnout, a Neurologic Crisis. And I want to quote a little bit from this article. It says, the prevalence of burnout is higher in physicians than in other professions and is especially high in neurologists. Physician burnout encompasses three domains. One, emotional exhaustion, the loss of interest and enthusiasm for practice. Two, depersonalization, a poor attitude with cynicism and treating patients as objects. And three, career dissatisfaction, a diminished sense of personal accomplishment and low self-value. Burnout results in reduced work hours, relocation, depression, and suicide. Burned out physicians harm patients because they lack empathy and make errors. So it's not just something affecting physicians, unhappy physicians, it's something that actually leads to poor quality medical care. The prevalence of burnout is high among neurologists compared to other specialties and currently exceeds 50%. I was quite shocked to read this particular statistic. Burned out physicians have poor job satisfaction and lack empathy, withdraw from practice, and have a documented higher error rate and poor patient outcomes. So again, physician burnout is not just about unhappy physicians, it's something that adversely affects patient care. So what solution do they offer in this article for physician burnout? Well, what they say is this. To avoid these sources of dissatisfaction, a few American Academy of Neurology committee members have privately advocated the radical position of severing all ties with insurance entities and establishing a cash-only practice. They are starting to whisper amongst themselves that maybe the best way to avoid physician burnout and provide better patient care is to get rid of all of the mind-numbing bureaucracy that goes along with third-party dependent care. And you will note that the radical position that they advocate is portrayed in years past by doctors like Dr. Ben Casey, Dr. Kildare, and of course Marcus Welby, MD. These are the radical types of physicians they believe they're talking about when they are considering severing all ties with insurance entities and establishing a cash-only practice. As most of you know, Medicare obstructs, impedes, and interferes with nearly every aspect of the practice of medicine. It's as if Medicare has its tentacles all over everything in your office. And many times you often feel like the 2,000-pound gorilla is standing right there between you and the patient, looking out for cost containment for the Medicare program. It's almost as if they force you to practice in a straitjacket. So what most probably are aware of is that there is a veritable army of bureaucratic minions out there whose sole purpose in life is to make your life more difficult and more difficult for you to practice medicine. You knew that these bureaucrats are out there. You just didn't know that this is what they look like. So what have the Medicare bureaucratic minions been up to recently? Well, all physician Medicare claims will be held for the first 2 weeks in 2015 in order to give Medicare contractors time to correct technical errors in the Medicare physician fee schedule. These are errors that were made by the bureaucratic minions. The minions, of course, tell us that the hold should have minimal impact on provider cash flow. As if it weren't enough to deal with all of the bureaucratic minions, there is risk of prosecution, prison, and ruinous fines running afoul of something involving the Medicare program. There are the Medicare fraud and abuse laws, the False Claims Act, the Anti-Kickback Statute, the Physician Self-Referral Laws, also known as the Stark Laws, the Exclusion Statute, and civil monetary penalty. The False Claims Act, also known as the Lincoln Law, actually dates back to the time of Abraham Lincoln in the Civil War. It was designed to punish those who charged the Union Army for 3 horses and only provide 2. This False Claims Act survives to this very day. And the punishments are treble damages, fines of $5,500 to $11,000 per claim under the criminal penalties, and potential $50,000 violation under civil monetary penalties, and up to 5 years in prison per violation. No specific intent to defraud is needed. It just has to be shown that the physician was acting in reckless disregard for the truth or falsity of claims, or acting with deliberate ignorance of the truth. And the standard of proof is very low. It's the preponderance of the evidence, which is just a smidgen beyond 50%. The anti-kickback statute prohibits receiving anything of value to induce or reward patient referrals. And the fines are also substantial, up to $25,000 per violation under criminal penalties, and potential $50,000 per violation under civil penalties. Prison time can be up to 5 years per violation. There are also some changes which have occurred under Obamacare. The violation of the anti-kickback statute is now automatically deemed to be a false claim. So the physician would be subjected to treble damages, $5,500 to $11,000 per violation in criminal penalties, potential civil monetary penalties of up to $50,000 per violation. So you can see when they put a number of violations together against you, you're basically out of business and bankrupt very quickly. The Stark Law prohibits a physician from referring Medicare patients for designated health services to any entity with which the physician or immediate family member has a financial relationship unless an exception applies. And in these cases, an overpayment refund must be made, and no intent standard for overpayment refund is required. And again, the physician can be held liable under the False Claims Act with all of the horrendous fines and penalties associated with that. And don't forget that we have the Medicare private bounty hunters, known as recovery audit contractors, who get a percentage of the take when they accuse the physician of overcharging Medicare. There are also the zone program integrity contractors, and these folks are looking to hook you up with a crime. And that's all in addition to the Medicare contractors' own fraud units and the HHS OIG, which also has a fraud unit. So what we have arrived at in the Medicare bureaucracy is a situation similar to that involving the former KGB slogan, which is, "Show me the man and I'll show you his crime." They pretty much point to almost anyone at any time and find something that you're violating within the Medicare laws, rules, or regulations. As most of you know, the war on doctors really was ramped up in April of this year when CMS released individual physician Medicare payment data. And you saw newspaper headlines like this, "Where the Medicare millions go." And of course, they had this all delineated by specialty. And if you look right there at the top, the specialty which apparently many of the millions go to is internal medicine. I think that leaves a somewhat distorted picture of things for the public, however. Interestingly, shortly after that front page article came out on where the Medicare millions go, another article in the same paper came out telling us of a doctor shortage found in Western New York. It didn't quite make a lot of sense. If all these doctors are making millions of dollars practicing and being paid by Medicare, why there would ever be any kind of shortage of physicians. So why has this escalation of war on doctors occurred at this time? At a time when people are encountering the sticker shock of unaffordable Obamacare insurance, and as Medicare continues on the path to insolvency, physicians are being made the scapegoats for high costs. Meanwhile, however, there is no mention of how much price discrimination in Medicare is costing patients. If you look at a typical office visit code, 99213, for instance, you will see that the total Medicare pays if it's provided in a physician's office is $72.50. But if the same exact service is supplied in a hospital-owned outpatient clinic, Medicare pays $123.38. The patient likewise pays a higher copay when the service is provided in a hospital-owned clinic as opposed to an independent physician's office. The Obama administration also strategically delayed cuts to Medicare Advantage programs, which is managed care, until after the 2014 midterm elections. Instead of cutting Medicare Advantage reimbursements, Medicare Advantage plans will receive a 0.4% increase in payments for 1 year. And don't forget, there are $716 billion in cuts to Medicare, which are planned under Obamacare, and about $156 billion of those will come from Medicare managed care cuts. So what about the sustainable growth rate, the SGR? Well, as many of you know, Congress recently passed a bill to delay the 24% cut in physician Medicare fees for 1 year through March of 2015. That was at a cost of $16 billion. The bill also delayed implementation of ICD-10 coding until October 1st, 2015. The cost of ICD-10 coding or switching to ICD-10 coding is substantial. It's estimated to range between $56,000 and $226,000 even for small practice to convert to ICD-10. Major disruptions to cash flow are anticipated this coming October. And don't forget that part of the funding of Obamacare depends on physicians absorbing a fee cut in the 24% range at some point. And while many physicians have been fixated on repealing the flawed SGR payment system, very few have noticed that a law has already been passed which will cut physician fees gradually over a period of time by 24%. The Budget Control Act of 2011 is the law that brought us the 2% sequestration cuts, which went into effect on April 1st, 2013 for a 10-year period. On December 26, 2013, the Budget Act of 2013 was signed into law, extending the sequestration cuts for an additional 2 years. Thus, what we have is a 2% per year cut times 12 years equals a cumulative cut of 24%. As there is no money to pay for a repeal of SGR, Congress is seeking other ways to drastically cut physician Medicare fees and to drastically change both the payment model and the ethics of medicine in our country. One of the main goals is to eliminate fee-for-service medicine and transition to a bundled payment model with restrictive treatment protocols under Obamacare's accountable care organizations. The value versus volume rhetoric that you hear being bandied about recently and how to permanently fix the SGR belies a monumental shift in medical ethics, doing what is in the best interest of the individual patient to doing what is most cost-effective for society as a whole. Physicians who remain in Medicare will increasingly be expected to act as agents of rationing in pursuit of value to society. The oath of Hippocrates will be made irrelevant, and patient trust in physicians will be destroyed. The solution, of course, is to kick the 2,000-pound gorilla out of your exam room and reaffirm your commitment to serving individual patients. You might be interested to know that the number of physicians who opted out of Medicare tripled between 2009 and 2012. And in 2012, a total of 9,539 physicians opted out of Medicare in that year. So, as most smart fishes can tell you, don't take the bait. They're going to flash this money in front of you. It looks like guaranteed money. All you got to do is send in the electronic claim. They're going to send you money, but there's a significant hook attached to that money. Don't take the bait. So what are some of the factors to consider in making an opt-out decision? Well, first of all, there are, of course, financial considerations. You need to consider the total revenue equation, which is gross revenue minus expenses equals net revenue. And what you find is once you get rid of the extraordinarily high administrative expenses associated with dealing with Medicare bureaucracy, you should be able to charge a reasonable fee and earn a reasonable income based on this net revenue equation. Number two, you need to look at the type of services you provide, the patient population you serve, and make some assessment about ability to collect directly from your patients. If you elect to stay in Medicare, you also need to consider the extraordinary costs, you and your staff, of keeping up with ever-changing Medicare rules and regulations, and the cost of filing and handling Medicare claims and appeals relative to revenue generated. If you decide to opt out, it may be very helpful for you to find niche services if possible, and you need to think about how to develop a marketing campaign to inform patients of the considerable benefits of seeing an opted-out physician. And one of the main benefits is, which all physicians can offer, is their time. Believe it or not, patients don't like to be rushed through like cattle with an 8-minute office visit where they're barely allowed to talk, if at all, and certainly not ask questions. So one of the things that you can provide your patients in an opted-out situation is more face-to-face time, allowing the patient to get the questions answered. You also need to consider the cost of non-compliance with a whole host of things, as I mentioned. ICD-10, if you're not compliant with that by October 1st this year, you will be subject to a 100% cut in Medicare fees. E-prescribing, of course, those cuts are already in effect, 2% cuts beginning in 2014. Meaningful use, which is, of course, meaningless when it comes to actual clinical utility, but if you don't comply with meaningful use, you can see that you'll be suffer a cut in fees of 1% in 2015, 2% in 2016, 3% in 2017, 4% in 2018, and 5% in 2019 and beyond. There's also PQRS, the Physician Quality Reporting System. If you're not compliant with PQRS, again, this is based on 2013 reporting activities, fees will be cut by 1.5% in 2015 and 2% in 2016 and beyond. Also, starting in 2017, CMS will make cuts to misvalued codes, what they call misvalued codes, mainly for specialists to meet budget targets. Many of you have already suffered some of these cuts. Cardiologists, radiologists, and nephrologists all suffered these cuts already, but may be in store for more. There's also this specter of maintenance of certification, and if you don't comply with that, first of all, if you do comply with that, they will give you a tiny little carrot of a 0.5% incentive bonus. But if you don't comply with maintenance certification, even if you're grandfathered in 2016, there will be a reduction in the CMS-based fees if you're not enrolled in maintenance of certification. Then there are, of course, the non-financial considerations, the freedom and pleasure of practicing medicine again instead of practicing bureaucracy, the idea of kicking the 2,000-pound gorilla out of your exam room, and in that case, happiness replaces physician burnout. That's of considerable value both to you and your patients. There's the positive patient experience and protecting patient privacy, which you can do better as an opted-out physician. There also is no fear of ruinous fines or prison time for inadvertent coding errors or running afoul of some obtuse Medicare law, rule, or regulation, and you don't have to worry about Medicare bounty hunters or the zone program integrity contractors coming after you. You're not taking your money, so there is no hook. Then there's simplification. Opt-out physicians need not use any codes in serving Medicare patients. No claims to file. No more constant Medicare hassles, more time to spend actually treating patients, more time to spend with your family. Basically, again, it's the experience and the joy of practicing medicine instead of practicing bureaucracy. In making your decision about opting out of Medicare, you should check all of your contracts and hospital bylaws to ensure that there are no conflicts. If you are unsure, ask an attorney to review your contracts and any other legal documents that may be pertinent. The procedure for opting out is actually pretty simple, but it's different for non-participating physicians than for participating physicians. Non-participating physicians can opt out of Medicare anytime during the year. A copy of the opt-out affidavit must be provided to the Medicare carriers that you deal with. If you deal with more than one, you have to supply it to each one you deal with. No later than 10 days after the first contract to which this affidavit applies is entered into. My recommendation, however, is that it's highly recommended that you provide the affidavit well in advance of the planned start of the opt-out period so as to accommodate the Medicare bungling factor. Medicare often loses things or just doesn't handle it appropriately, and you need time to account for that. There also is a 90-day grace period after filing the first affidavit during which the physician may withdraw the opt-out affidavit. Again, be sure to check other contracts and affiliations you may have which may require participation in Medicare. Participating physicians can only opt out 4 times during the year. The Medicare contractor must receive the opt-out affidavit 1 month before the beginning of each quarter. Deadlines for the carrier receiving opt-out affidavits from participating physicians are March 1st, June 1st, September 1st, and December 1st. Also, you need to be aware that opt-out physicians cannot make private contracts with patients under emergency or emergent conditions. In those cases, you will need to file a claim with Medicare if you're treating a patient in an emergency room for the first time, for example, and you'll be treated like a non-par physician in Medicare for that particular claim, and that means that all non-par allowed amounts in Medicare and limiting charges apply to services provided in emergency and emergent conditions. You can have an early termination of opt-out, but it requires that you not have previously opted out of Medicare, so it only applies to the first time you opt out. You must notify all Medicare carriers of the termination of the opt-out no later than 90 days after the effective date of the opt-out, and you must refund to each beneficiary with whom you have privately contracted all amounts collected in excess of the Medicare limiting charge. You must also notify all beneficiaries with whom you entered into private contracts with of the termination of the opt-out and their right to have claims filed on their behalf for services provided during the opt-out period. The physician is then reinstated to his prior Medicare status as if there had never been an opt-out. Most importantly, you can download the simple step-by-step instructions for opting out of Medicare, and using private contracts, you can download the opt-out affidavit from our AAPS website. We also have sample letters informing patients of your decision to opt out, and you will find answers to questions about opting out again on our AAPS website. You will also find a list of physicians on our website by state who have opted out, videos of talks given by opt-out physicians about their experience and tips for success, and there's a list of physicians in various specialties who are willing to serve as mentors and answer specific questions regarding the opt-out experience in their particular specialty. AAPS also offers these Thrive, Not Just Survive seminars a couple of times per year at different locations throughout the country. And again, AAPS has been offering these seminars for about 13 years now. And I would point out to you that a tax-deductible donation to our AAPS Educational Foundation can help us expand our medical student program and allow more medical students to attend not just these Thrive, Not Just Survive seminars, but annual meetings as well. So here are some of the tips for opting out. Number one, start at least 6 months in advance of the beginning of the opt-out period. This provides you with the necessary time to properly inform your patients of changes and time for you and your staff to adjust. Filing the opt-out affidavit 6 months in advance of the start date, as I mentioned, also will accommodate the Medicare bundling factor. When you send your affidavit, which should be sent certified mail return receipt, you need to enclose a cover letter specifically requesting written acknowledgement that the opt-out affidavit has been properly accomplished. You also need to mark the calendar so that you will remember to renew your opt-out 6 months in advance at the end of the 2-year opt-out period. Remember, opting out of Medicare is not like a divorce of Medicare. You have to renew your divorce every 2 years. You also have to renew the patient private contract every 2 years as well. And you need to have office procedures in place so that there is no Medicare claim being filed except for those services provided in emergency circumstances. Again, if you have any specific questions about opting out of Medicare or transitioning to a third-party free practice, feel free to contact and call AAPS, and we'll do our best to help you. And I can now take a couple of brief questions if you would like. Thank you.
Do you have any questions for Dr. Huntoon up in snow-drenched Buffalo?
Howard Hyde, spouse of a physician and free market advocate. This question can be for both Dr. Huntoon and Dr. Counselor Schlafly. What do you say to the critics who say that the doctors had it coming because they were at the unjust enrichment feeding trough with Medicare in the previous generation, and now they're just suffering the just desserts of that behavior?
Well, that's a very good point. And if you look back in AAPS history, AAPS warned about that very thing many years ago, and physicians didn't listen. They thought it looked like easy money, and they went for it. And so to that degree, I think that those physicians are partly to blame for what has happened.
The question is, do you see a time when your license is going to be attached to participating in Medicare?
Well, that certainly could occur. I think that would be fought very aggressively. And I know that in Massachusetts, it's not a requirement that you participate in Medicare, but they do have a law that says you cannot charge any more than the reasonable Medicare amount. So there is not yet a state that has required participation in Medicare for licensure, and I think that they would be on thin legal status to do that, and I think we would certainly challenge that.
But then again, we have a president who does what he wants to do, regardless of the law. and Congress does not seem to be willing or able to stop him. So, plus there's tremendous amount of power embedded into the Affordable Care Act.
Ray Pajic from New Orleans. The lecture that you gave is excellent, but it was also pathetic. I'm an older surgeon who probably bypassed a lot of this nonsense that was presented to us about Medicare. What frustrates me is that there are approximately 850,000 physicians in this country. Of those, maybe 700,000 are really working or seeing patients. The administrators and many hospital accountants and non-physician employees are making millions of dollars, and they don't have to go through all of these nightmares that you have just presented to us. And my frustration is that physicians, after all the educations that we have had to become specialists or whatever, have to be subjected to this petty accounting procedures. The real cost in healthcare in this country is not the doctors' salaries. As we all know, that on the average doctor's salary is between $100,000 to $500,000 a year, no matter what you do, unless you're in the top 5% who's making more than that.
Do you have a question?
Well, my question is, why are the physicians allowing themselves to be subjected to this nickel and diming that we just presented? That's my question.
Well, I think if you recall the slide with the dollar dangling from the hook, that's basically it. They tried to take what they viewed as the path of least resistance to the money, not realizing there would be significant strings attached to that. Before I opted out of Medicare in 2004, I was spending 40 to 50% of my professional time doing nothing but fighting Medicare bureaucracy over errors they made, and they did not follow their own regulations. I never lost a battle that I fought with Medicare, but spending 40 to 50% of your professional time doing that is outrageous.
We're going to move on. I just wanted to say that you made another very good point there, which is that the vast majority of of the Medicare budget does not go to doctors. Doctors get about 8 or 9% or so of the Medicare money.